Thank you, Dr. Charan, taking us through the extracorporeal support in the shock. What are the options and the indication? Now, moving to the next lecture, it is a liposomal amphotericin B versus Isuvaconazole in invasive mucormycosis by Dr. Ankit Mittal.
Good evening, all. Thank you for inviting me. This is my first association with ISCCM. I'm relatively new to Hyderabad also, and the topic provided to me was to discuss liposomal amphotericin B versus isavuconazole for invasive mucormycosis. Now, we all know about mucormycosis. I think we'll not go into details of mucormycosis per se, but everybody who has managed a case of mucormycosis probably knows that it's one of the most expensive diseases to treat, with costs outrunning even transplant related costs or cancer chemotherapy related costs, and still have worse outcomes as compared to those diseases. So I don't have any disclosures, and since it's only a 15-minute talk, I'll try to stick to the topic proper, and we'll talk about a little bit of overview of antifungal options, because we are going to discuss liposomal ampho B versus isavuconazole, review of current guidelines instead of going into details of each studies. But there's a recent update which has compared outcomes with different antifungal options, and then we'll try to summarize. And I'll try my best not to show very ghastly images of patients with mucormycosis. The image on the slide is basically lactophenol cotton blue mount, KOH mount, which is really helpful in diagnosing. It's a very quick bedside diagnostic test which can tell us the diagnosis within an hour or so. And then of course the GMS staining and the PAS staining for histopathological examination. Now, antifungals against mucormycosis, as of now, what we have in our arsenal is amphotericin B and its various formulations, posaconazole and isavuconazole. Then newer antifungals, which we still don't know if they'll work well against mucormycosis, things like ibrexafungerp, polorifem, fosmanogepix. But as of now, we have very limited options for treatment of mucormycosis. Uh, Within amphotericin B, we have several formulations that are available. Now, I really don't have much experience using lipid complex colloid dispersion. In fact, not even used a lot of deoxycholate because the practice is kind of obsolete given its very high incidence of adverse events. Posaconazole, isavuconazole, relatively newer molecules. Perhaps 2016-17, the suspension was in a lot of use with posaconazole. Now everybody has moved on to tablet forms, and isavuconazole is still a newer molecule. Amphotericin B is a very broad spectrum antifungal which basically causes pores and lysis of the fungal membrane, and which leads to cell lysis, cell death. The problem with amphotericin B as of now, it's only available in intravenous formulation. Now there's a recent study which has looked at an oral formulation, especially for cryptococcal meningitis treatment, but still not available. It has very poor penetration into CSF except in very high doses, and that could be a challenge when you're managing, especially rhino or cerebral mucormycosis. Major problems with amphotericin B: infusion related issues, fever, chills, nausea, renal toxicity, which can really become challenging, and electrolyte imbalances like hypokalemia and hypomagnesemia. I'll quickly discuss the or compare the different amphotericin B formulations that are available, highlighting their key aspects. So if you look at the conventional form, which I think very rarely is being used these days, the toxicity and infusion reaction rates are really high, and that's why we cannot really go with higher doses. The maximum you can go with conventional ampho is approximately 1 milligrams per kg per day. However, the cost is really low, and it can be very helpful for where cost becomes a major issue. And other ones, liposomal amphotericin B, lipid complex, colloidal dispersions, of which people are most comfortable using the liposomal forms. Now, what I want to highlight here is that liposomal amphotericin B in itself is not a very uniform molecule. Every pharmacological product of liposomal amphotericin B is going to be different. So maximum literature that is available, it's available with the Gilead molecule, which is the ambisome, which is the the original molecule, and everybody else has tried to replicate the molecule, and a lot of formulations are available in the market. It is best going by the experience which one's patients tolerate better, because there's absolutely no head-to-head comparison available for most of the formulations that are available with liposomal amphotericin B. Posaconazole, again, a very broad spectrum triazole antifungal. This inhibits the ergosterol synthesis, causing disruption of the fungal cell membrane. Advantage is that it is available in oral formulation. It does causes side effects, need to monitor liver enzymes, QT prolongation. And talking about the molecule of our interest for the presentation, which is Isuvaconazole, again, it's a very extended spectrum triazole, more favorable pharmacokinetics. So amongst the triazoles that are available, first one was the voriconazole, which has absolutely no activity against mucormycosis. The challenge is to optimize the drug levels. Again, with posaconazole, initially the suspension had very questionable drug absorption, drug levels were not adequate. Then the tablet formulations came, where initially it was claimed that drug levels do not need to be monitored. But in routine practice, we have seen that sometimes posaconazole trough levels are also difficult to achieve. With isavuconazole, it is proposed that the formulation does not require therapeutic drug monitoring. It's much better tolerable. It does not cause QTC prolongation. So except for amongst all triazoles, isavuconazole is the one which does not cause QTC prolongation. But where is its space, or how did it come into picture for treatment of mucormycosis? So this was a very small study published in 2016, where they did not even do a head-to-head trial or comparison. All they did was they did a 33 patient or 20 patient on isavuconazole, and they took retrospective control from a fungiscope directory with 33 patients, where they looked at outcomes of patients with mucormycosis who have received amphotericin B. Also, we do not know for sure if it is all comparison with liposomal formulations of amphotericin B or with different formulations of amphotericin B. But what they found out is in the patients who received isavuconazole, they did not perform worse than the patients who had received amphotericin B for treatment. And the comparison was 33% mortality in the isavuconazole group versus 39% mortality in the amphotericin B group. And they did try to look at how did it affect if the patient had a hematological malignancy or a severe disease, or whether a surgical debridement was done. So they could not find very gross differences, although the sample sizes are very, very less. But what this helped is this gave the drug FDA approval for management of mucormycosis. The dosing is 200 milligrams TID into 2 days, followed by 200 milligram once daily. Now, again, major limitation is cost of treatment. Both the molecules of interest, amphotericin B, the liposomal formulation, and isavuconazole, both have a very, very significant cost implication. However, between the two, the cost of liposomal amphotericin B treatment is going to be significantly higher when we compare to a drug like isavuconazole. So moving on, I'll talk about the guidelines, the global guidelines, which was published in 2019 for the management of mucormycosis by the MSG-ERC group. And here, what they have clearly mentioned is that liposomal amphotericin B remains the first choice. We need to start at 5 to 10 milligrams per kg from day one. Avoid slow escalations. If there is brain involvement, or if the patient is having a solid organ transplant, it still maintains liposomal amphotericin B. Only if there's a pre-existing renal dysfunction, it strongly recommends using an alternative therapy. So unless there's a special situation, or for some reason you're not able to use liposomal amphotericin B, that is when the guidelines recommend that you can go for a alternative treatment like isavuconazole and posaconazole, and the guidelines do not prefer one over the other. And if you look at, if the patient is already on treatment and based on the progress, so if there's a stable disease or partial response in the disease, the guidelines are not very clear whether you should continue with the primary therapy or you should step down. So that's a big, that's an area of research gap. If there's a progressive disease, again, absolutely nobody knows what to do, but the general consensus is to just switch to the alternative therapy. So if the patient was on Ampho, try Isuvaconazole. If the patient was on Isavu or Posa, try Amphotericin B. And again, if there's toxicity, you need to adjust based on the toxicity. So key recommendations where the first line still remains liposomal ampho. If there's renal toxicity, dose can be reduced as necessary. But the problem with dose reduction is the efficacy of liposomal amphotericin B in mucormycosis is studied at 5 mg per kg per day and above. So if you're having to reduce the doses to below 5 mg per kg per day, we really don't know if the patient is going to do well with that treatment or not. Isuvaconazole, they have made a moderate strength of recommendation. Uh, Again, marginal support for posaconazole suspension. Duration, nobody knows because you have to treat as long as there's no good clinical response, clinical and or radiological response. So comparing isuvaconazole and liposomal amphotericin B, both are expensive therapies, but the cost of isuvaconazole is going to be lower. But should isuvaconazole be the first line therapy or a step down therapy or an alternative only if you are not able to use liposomal amphotericin B still remains questionable. However, there are certain advantages with isuvaconazole. The most important advantage being that it's available in oral formulation with reliable pharmacokinetics. Since the patients might be requiring a very long duration of antifungals going on for months, we definitely need to have something which is oral and convenient for the patient. So this was about the recommendations as per the current guidelines, right? But what is the most recent evidence base for uh, therapeutic outcomes with antifungals in mucormycosis? So this was published by Dr. David Denning and Dr. Sigera in 2024, where they have looked at 10,000 patients that have been published. Most cases are from Asia. So why I like this paper is because it is truly reflecting our scenario. Majority of the patients reported in this paper were from Asia. Diabetes was the most common risk factor. Rhino-orbitocerebral mucormycosis was the most common manifestation. And but the duration and dose of antifungals varied widely. So what they've done is approximately 4,800 patients received amphotericin B either alone or in combination. And the predominant form of amphotericin B that was used was liposomal. So approximately 4,000 patients received liposomal amphotericin B. Now, if you look at the third column on that table, which shows the percentage mortality, with amphotericin B alone, it is close to 32%. And if you look at posaconazole or isuvaconazole associated mortality, it's around 17 to 24%. So it looks like that the mortality with azoles is lower than with amphotericin B, but the difference is not statistically significant except for in posaconazole. Again, but the sample sizes for comparison is very different. 4,000 patients received ampho, whereas only a few hundred patients received azoles alone. But what is interesting to note here is that if you compare the outcomes of patients who are treated with both amphotericin B plus azole, the mortality was the lowest. And amongst azoles, the mortality was lower with posaconazole than with isuvaconazole. So in this scenario, what we are actually seeing is not ampho versus an azole. What we are probably looking at is an ampho plus azole, right? In special situations. Now, I'll talk about the limitations of these findings because this should not be generalized or extrapolated to each and every patient of mucormycosis. Also, most important thing that they have highlighted, although again the number is small, outcome of surgical management. If the surgery is done, the mortality is much lower, and if the surgery is not done, mortality is much higher. So what they have concluded is both combination and sequential therapy. So I forgot to show you this. So if you look at the last yellow bar on the first graph, Ampho followed by an azole also had a lower mortality. This could probably because patients don't tolerate amphotericin B alone, but once you step down onto an azole, the tolerability improves and the patients can be on a longer duration of antifungal therapy. So both combination and sequential therapy of azoles with or after the amphotericin B seem to be the superior strategy, but this could reflect survivor bias. So that is the biggest problem. Posaconazole and isuvaconazole as monotherapy also have promise as alternatives to ampho B. But again, this is something which should be still in reserve. shouldn't be first line. We should try to go ahead with liposomal ampho B, if possible, in combination with azoles if cost is not an issue. Key limitation of the work relate to the lack of detail and complexity of most patients. So this is probably the major takeaway, that every case of mucormycosis could be very, very different, very, very complex, and therefore do not go solo for managing mucormycosis. Always talk to the surgeon. Reduction of the disease burden is most important when we are talking about managing mucormycosis. In addition to, either you give a combination with ampho plus azole, or you choose ampho over azole or azole over amphotericin B. So mucormycosis is a medical emergency. Surgical debridement is the first step whenever possible. Ampho B is still the preferred regimen as per guidelines, and we should avoid slow escalation of doses. If required, Isuvaconazole or even posaconazole can be reasonable alternatives for liposomal amphotericin B. And for select cases, you can go for combination for, in fact, better outcomes. So with this, I'll just add today's 1st December to just to remind everybody about World AIDS Day, and thank you. That's my time. If there are any questions, we can take them.